Hello, and welcome to the Heart Health Lecture Series hosted by the Center for the Prevention of Cardiovascular Disease. Thank you so much for joining us. My name is Anya Coates, and I help coordinate this series for our moderator, Dr. Dennis Goodman. Dr. Goodman is clinical professor in the Department of Medicine. He's also the director of our integrative medicine program at the Leon H. Charney Division of Cardiology, and a member of the Center for the Prevention of Cardiovascular Disease. We'll have a dedicated time at the end of this webinar to take your questions. We invite you to submit your questions at any time during this webinar using the Q&A feature. We've also received some of your questions via the registration form. Upcoming in May, we have an exciting lecture on improving your health through your gut microbiome. You can register for this event using the website noted here at the top of the slide, nyulangone.org/hearthealthlectures. This will be our last lecture for the spring series, and we'll go on our usual summer hiatus and return back in the fall with an exciting lineup. This image here just shows some of the over 50 topics that we have covered on heart health and conditions that increase your cardiovascular risk. This program was started in 2015, and many of these lectures have been recorded and are available for you to view on our lecture library, which is on NYU Langone's YouTube channel. If you want to grab your phone, and you can use that QR code, that will take you directly to our playlist, where we have over 30 videos archived for your viewing. And we're excited to extend the educational impact of this series. As you can see, we've had over 93,000 views of our many online lectures. We invite you to keep in touch. Here's some of our contact information, our website. You can email us with questions. And we also have an Instagram and Twitter account, and that's our handle there. And we invite you to stay in touch so that you can hear about upcoming lectures, the latest research news and publications of our faculty, and to hear what's going on at the Center for the Prevention of Cardiovascular Disease. It is my great pleasure to introduce you today our NYU Langone expert, Dr. Jonathan Newman, who is the Eugene Braunwald Assistant Professor of Cardiology in the Department of Medicine and is board certified in internal medicine. He received his Master's of Public Health and medical degree from Northwestern University. Dr. Newman completed his internal medicine residency, chief residency, cardiology fellowship, and cardiovascular training at Columbia University. Dr. Newman is a physician scientist and an expert on the link between environmental exposures like air pollution and how those exposures contribute to cardiometabolic diseases, such as diabetes and cardiovascular disease. He will be leading a randomized clinical trial supported by the National Institutes of Health to test the benefit of indoor portable air cleaners to improve indoor air quality and lower blood pressure. He has received additional funding from the NIH and the American Heart Association and has published over 150 peer-reviewed medical journal articles. Dr. Newman is a member of our Prevention Center, and we are thrilled to have him speak on this important topic today. Dr. Newman, I invite you to share your slides.
Okay, great. Can you see my screen okay, Anya?
Let's see. I'm gonna not see mine. Yes, I can. Thank you.
Okay, terrific. Thanks everyone for attending, and thank you, Anya, for the very kind introduction. I believe my wonderful parents are in the virtual audience, and some of her their friends. So I appreciate the additional support. So as Anya indicated, I'm going to try and do a little bit of a run through on some of our research and what's known, and maybe personal strategies to reduce cardiovascular risk through some personal approaches for reducing cardiovascular risk from things that are not really considered traditional risk factors for heart disease. So let's jump in and get started. I will hopefully move things along. I think we heard this about disclosures. Okay, so as a bit of an overview, I'd like to start with sort of telling you what we're going to talk about, and then at the end, I'll tell you what I told you, and we can then discuss some of the questions or any issues that may have come up. So I think I'll try and convince you or show to you some of the data regarding the importance of environmental factors for heart disease, maybe a framework in which to think about this vis-a-vis major agents or major pathways. And I'm going to spend some time talking about preventive strategies, areas of environmental exposures and health inequity, and some evidence of our work into testing and evaluating personal strategies to reduce the cardiometabolic risk from common environmental exposures. There's a tremendous amount that I can't talk about, but I will try and keep this focused on some of the areas in which we're doing some active work. So this was a review paper that was published in the New England Journal of Medicine recently, within the last year, that really outlined both potential potentiators and mitigators of environmental pollutants and their cardiovascular effects. And I wanted to highlight some of these. I will spend the majority of time today talking about air pollution and particular fossil fuel combustion related air pollution and its cardiovascular effects and ways to mitigate some of those effects. But there are lots of others that contribute to adverse health effects and adverse effects on cardiovascular risk factors. And this is just to show you in this figure the ways in which, and it's important to kind of highlight throughout the talk today, that there are many factors that we're exposed to that are not individual. None of us are exposed to one factor alone, meaning you can be exposed to air pollution and also other effects of climate change. In fact, it's very common that these are mixture related or multiple exposure related phenomena. But in the case of things like air pollution, we know that fossil fuel-based transport, industrial pollution, and energy-intensive farming worsen air pollution. And in contrast, green spaces, green energy, local food sources can ameliorate or mitigate some of those effects. Similarly, with manufactured chemicals, petroleum-based plastics, refrigerants, and pollutants can potentiate the use and distribution of manufactured chemicals, but in contrast, using other alternatives to plastics or other organophosphates like PCBs or BPAs, using other alternatives can reduce our exposure to some of those ubiquitous environmental exposures. And other areas, myself and other investigators are doing a lot of work in other quote unquote toxic metals, including lead and cadmium, and maybe clinical methods to reduce the adverse health effects of those exposures. One thing that's important to note, though, is that there's really these environmental exposures are pervasive and important. And it's been almost 10 years since the WHO has identified, the World Health Organization has identified air pollution as the world's greatest environmental threat. 80% of the mortality from air pollution and a corresponding increase in morbidity is due to actually heart disease, CVD, cardiovascular disease, or stroke, cerebrovascular disease. And it's important to note that the effects of air pollution occur far below regulatory standards. There's really no level of safe air pollution exposure. The question is whether or not we can achieve those levels of exposure in cost-effective modalities. And this is a slide from some collaborators that highlight both the different routes of exposure, the initial physiologic response, sort of what your body does once you're exposed to, whether it's lead or phthalates or PCBs or air pollution, the molecular effects that may have, and importantly, the way in which our other metrics of health or cardiovascular wellness, like diet or lifestyle, our innate genetics, which we cannot modify, can in turn affect some of the burden of those health effects. The subclinical effects, meaning before, let's say, you have or develop a risk factor or a cardiovascular event, what's going on with your blood's clotting? How does it change the way your body may form or resolve plaque? What does it do to the structure and function of your heart? And eventually leading downstream to all sorts of potential adverse outcomes. I want to talk a little bit, sort of focus the discussion a bit about air pollution. And what we're going to focus on, and is highlighted in red here, is PM 2.5. So that's particulate matter less than 2.5 micrometers in diameter, about the size, usually somewhere between a bacteria and a red blood cell. In contrast, a human hair is about 70 micrometers in diameter. So these are not, PM 2.5, its main source has been driven by fossil fuel combustion. It's composed of a whole host of elements. And we know that this is the main driver of adverse health outcomes. In general, these particles are, as mentioned, they're larger than some of the ultrafine particles, and that they are widely distributed. So there are ranges in which these particles may be, let's say, combusted in large cities, but then due to air distribution or weather patterns can have health effects distances that are much further away. And kind of to highlight again, to reiterate the burden of air pollution, in particular of fossil fuel combustion, PM 2.5, again, the fine particulate matter less than 2.5 micrometers in diameter, is the fourth leading risk factor for global mortality, predominantly due to cardiovascular disease. So it's up there in terms of high blood pressure, diabetes, and cigarette smoking in terms of a risk factor that we can address to improve longevity and wellness. So we know this, and there's been a lot of work that we and others have done to try and understand specific organ systems that are vulnerable to air pollution. And we know really there's no part of your body that is protected effectively. Most people, when they think of air pollution, think about the respiratory systems, their lungs exacerbating, let's say, the burdens of asthma or chronic obstructive lung disease or emphysema. But we know that increasingly air pollution has effects on cognition. It appears to increase the rates of stroke. There's increases in stress hormones. And there does appear to be increasing evidence of neurodegenerative diseases related to higher levels of air pollution. And when we think about distributions of air pollution, when you're exposed to something that's so common and so ubiquitous, even if the magnitude of effect is relatively small, because so many people are exposed, reducing that exposure can have large population-wide effects in terms of health outcomes for many, many people. We know, just to give another kind of step back, about pathways in which air pollution leads to heart disease events. We know that there are both direct effects, that air pollution directly affects the function of your vasculature. It directly causes central nervous system inflammation and different changes in your hypothalamic and pituitary axis, sort of what regulates a lot of your stress hormones. And it also has systemic and sort of biological intermediates that affects inflammation and thrombosis in terms of causing cardiovascular disease. Now, a lot of this work has been known and worked out for over 20 to 30 years, that both in studies of human individuals and people, to animal models, to more experimental systems, of the ways in which air pollution in particular, has a whole host of health outcomes. What I want to shift your attention to a little bit is what in our work we've taken to focusing on, or calling, the twin epidemics of both environmental and health inequities. And we know that communities in the United States and worldwide are disproportionately exposed and suffer from health outcomes related to and that exacerbate the effects of air pollution and other environmental exposures. So particularly under-resourced or underserved communities of impoverished individuals, both in urban and rural areas, are exposed to greater environmental hazards, whether it's lead, cadmium, or air pollution. These individuals and communities have greater exposure relative to their production, to their sort of participation in generating these meaningful forms of pollution, leading really to concepts of air pollution or environmental inequity. And at the same time, these same communities are both disproportionately burdened with high blood pressure. Over 50% of US adults meet thresholds for high blood pressure, a cutoff of a blood pressure of 130 millimeters of mercury systolic, over 80 millimeters of mercury diastolic. 10 to 15% of the US population overall have diabetes, and over a third of individuals age 65 and older have diabetes. And again, under-resourced communities have the highest prevalence of high blood pressure and diabetes. And what I want to draw your attention to is a really wonderful book that I would really recommend everyone in the audience to read if you're not familiar with it. Written by over 20 years ago now by a sociologist and a professor. He's had appointments at a number of different institutions, that basically looked at the effects of historical redlining, which I'll talk about, and discriminatory lending practices in the United States in both urban and ex-urban areas, beginning in the 1930s, and the way that has perpetuated economic and socioeconomic deprivation in this country. It's a really beautifully written book that draws really attention to a number of persistent issues in many, many areas of this country. And recently, there's been some really interesting work to show that how the effects of redlining, a discriminatory mortgage practice, relates to present day intra-urban air pollution disparities. And basically what these investigators did within the last year was to look and to say, if we look at the effects of redlining, and basically what redlining did, if you're not familiar with it, was that the Federal Homeowners Loan Corporation would rank different neighborhoods based effectively on their racial composition. And they would say that if you were in a predominantly white neighborhood, you were group A. And if you were in a predominantly African-American or Black neighborhood, you would be in a group D. And those would affect your ability to secure either predatory or more beneficial loan practices, or to secure loans in general for development. And what they found was that these redlining practices from A, B, C, and D, as the grading responsibilities went for the Homeowners Loan Corporation, directly related to burdens of air pollution more than 80 years later. And we know that these big disparities were substantially larger by redlining grade than by race and ethnicity. So if you were an impoverished Caucasian individual, a white individual living in Chicago, Illinois, in a redlined area, your levels of air pollution exposure are proportionally much greater than someone who's living in an area that's weighted, that was not redlined, that was a grade A lending model for the homeowners loan corporation, perpetuating these levels of air pollution exposure. And to give a little bit more context, this is a busy slide, but what I'm showing you here is that these investigators around the same time, the same group, linked basically air pollution exposure by race, ethnicity, and a crude measure of socioeconomic status. And what they showed is that non-Hispanic whites really have a pollution advantage, that they, as is highlighted in this top figure here, non-Hispanic whites are causing more air pollution in this case, but are experiencing the health effects or exposed to it much less proportionally than Black and Hispanic communities, leading to these authors publishing a really interesting analysis of a pollution inequity, that relative to the amount that, let's say, communities of color are producing of air pollution, they are disproportionately exposed. And this both relates to some of the redlining data and also just exists in terms of consumption practices and air pollution generation overall. Now, the reason why this matters is that recently, and this is an analysis from the New England Journal published within the last year, the Environmental Protection Agency is moving to lower its standard for PM 2.5. Remember, the particulate matter less than 2.5 micrometers in diameter. There are national federal standards based on EPA monitoring stations for which localities and different both residential and urban areas need to meet for certain air quality metrics. The standard has been lowered. The current standard is 12 micrometers per meter cubed, and it's been lowered to 8 micrometers per meter cubed. And what these investigators did is using data from Medicare data from 73 million people aged 65 years or older from 2000 to 2016. What they looked at the hazard ratios for death if you went from the current standard of 12.5 micrometers to 8 micrometers, or 12 to 9, or 12 to 10, 12 to 11, and they used Medicaid eligibility, the national sort of backstop of insurance for individuals of traditionally lower socioeconomic status, and consider those who are ineligible for Medicaid as being higher income. So very crude discrimination of income. But what they showed is very interesting, is that white individuals that are at higher income status derived less of a benefit proportionally with this reduction in air pollution standards, going to a more strict cutoff for PM 2.5 than poorer white individuals or Black individuals, regardless of their socioeconomic status. So really, I think it gives some credence to the idea that by lowering or tightening our, let's say, standards or our goals towards environmental equity, we can improve pre-existing socioeconomic and environmental inequities in communities that are already or that are currently disproportionately burdened by these exposures. Now, one of the things as a physician that I've been more interested in is, policy and policy change is very slow. Some might say glacial, but since the glaciers are all melting rapidly, they may not be the best analogy. And I'm interested in some level of what we could do on the individual level to benefit or reduce some of the effects of air pollution exposure. And there are other ways, other strategies that are being evaluated to reduce the effects of other environmental exposures, be it lead or cadmium, with infusion therapy, or other ways that we can maybe reduce some of these health effects. And this is a slide that we've used for some of our work, really to show that air pollution has all these health effects, but maybe we can reduce some of those effects by using personal or portable indoor air cleaners. And one of the things that we have shown, and we are now going to test in a larger clinical trial, is whether using these air filters overnight in your bedroom can lower your blood pressure. And while the benefit may be somewhat modest, I'm showing you a famous figure from cardiovascular disease epidemiology, that was initially used to show a population benefit for reducing salt and lowering blood pressure, and how that might translate to reductions in stroke and CHD, which is coronary heart disease, showing you that perhaps if we use PACs, the portable air cleaners, we could lower blood pressure, and just going from a 2 to 5 millimeter reduction in blood pressure could achieve on a population level pretty striking reductions in stroke and coronary heart disease, potentially just by improving indoor air quality. So to sort of reframe this another way, on the population level, we obviously need to make big strides with air quality guidelines and national and local ordinances and regulations as we move to some renewable energy strategies, reduce the effects of ambient air pollution exposure. But I would argue that while we do this, there are personal things that we can do to reduce those health effects. This slide was made, before the COVID-19 pandemic, during which time and after which the use of face masks or N95 respirators has become, unnecessarily controversial. But we and others have shown that portable air cleaners, HEPA filters, or high efficiency particle air filters or high efficiency particle arrestants, can reduce personal exposure to air pollution. There may be other personal strategies or medications that can further modify some of that risk. So there are things that we could potentially do as individuals to reduce our cardiovascular burden from things like air pollution. So I'll give you a little bit of, what are these portable air cleaners? As I mentioned, the things that we're focused on are the PM 2.5. So less than 2.5 micrometers in diameter. Again, giving you other comparisons here. We know that using these portable air cleaners, they're relatively affordable, about $100 per device, capture more than 99% of small particles in, an area. It varies on the size of your filter and the size of your room. But we and others have shown that if you use a personal air cleaner overnight in your bedroom, you can decrease your odds of respiratory symptoms in people that have asthma or emphysema, that there appears to be a benefit in lowering your blood pressure, improving heart rate variability, reducing blood biomarkers of stress or inflammation. And ultimately, these need to be cost-effective strategies, and that it appears in some of these models that it's highly cost-effective when used by certain common benchmarks, like paying for a year of dialysis, things like that. So we have shown, this is a meta-analysis that we did a couple of years ago with a talented medical student that worked with me, led this, that overall in a number of studies, both in the United States and overseas in areas that have much worse levels of particulate air pollution compared to the United States, that using a personal air cleaner could reduce your systolic blood pressure by about 4 millimeters of mercury. These are just showing you the different groups in the study and the way that we analyze the data, but about 4 millimeters of mercury overall, and a trend, although it's non-significant, towards a reduction in your diastolic blood pressure. The top number is your systolic, the bottom number is your diastolic, reflecting both systole, or kind of contraction of the vascular system, and diastole, or relaxation. And a cardiology fellow working with me also showed that these personal air cleaners, portable air cleaners, can reduce blood markers of inflammation, like C-reactive protein, which is a common inflammatory marker that really is increased in response to multiple things, to stress, to infection, or other markers that are a little bit more specific to inflammation and atherosclerosis, including some of the cytokine family, one of which is called interleukin-6. that using these compared to people that have a sham filter or no filter at all, those individuals or the periods of time in which active filtration was performed, you can lower some of these blood markers of inflammation. This is another study, a really interesting study showing that, sorry, apologies. Showing that even in younger individuals, this was an interesting study done in Shanghai at Shanghai, China, much higher levels of air pollution exposure, that you can lower stress hormones in highly exposed populations, cortisol, epinephrine, norepinephrine, other markers of corticosteroids, by using high efficiency particle arrestance monitors, air filters compared to sham. So really, I think maybe what we're getting to is this strategy to limit, approaches to limit the effects of air pollution overall, that maybe personal strategies, as we work towards population level and nation and worldwide strategies to reduce the burdens of air pollution, personal strategies like air filters, either on the individual or personal level, may be particularly helpful to reduce some of these health effects. And I show other things here that I don't have the time to really get into much, but whether it's using effective cook stove ventilation or natural gas, using electrical power for cook stoves, using high efficiency particle arrestants in automobiles during periods of heavy traffic. There are individual strategies that we can take. And again, to sort of reframe the discussion a little bit, of a small amount of change on a population level can have really meaningful reductions in things like blood pressure. So I wanted to, as we kind of come to the end or leave some time for discussion, there are lots of personal choices that you can make to reduce your contribution to climate change. And this was a nice analysis that was done a number of years ago that then was translated into a graphic. And to give you a sense of sort of where we are as an individual strategy, and the value basically of that strategy for developed countries, on current emissions now, almost 6 to 7 years ago. And you can see here, upgrading light bulbs, hang dry your clothes if that's an option for you, certainly recycling, replacing a car with a hybrid, shifting away to, maybe it's not sustainable for you as an individual to give up eating animal proteins, but shifting towards one that has less animal protein is certainly a wise environmental choice in terms of generating and reducing the effect of CO2 generation and climate effects. Switching to electric car, or even going car free as an option if that's possible. Buying green energy is a strategy that may get increasing economic weight as we have larger policy recommendations to support this. Avoiding flights, and you can sort of buy credits and make donations depending on your travel patterns of reducing your fossil fuel consumption through reducing your travel needs or changing your travel plans. That may not be possible. And the largest, although with a grain of salt, having one fewer child, kids generate a tremendous amount of fossil fuel generation, and making decisions about family planning, et cetera, can have meaningful effects on climate change and CO2 generation. I want to talk for a few minutes about other environmental exposures. And I don't want to give short shrift to any, but each of these could be talk in and of themselves, and we're not exposed to one thing alone, which I think is really a key message for a lot of this. In particular, noise, there's a very well-established link between noise and cardiovascular disease. I'm showing you here a paper from a nice review paper that's about 5 years old, showing the WHO and certain international guidelines for decibel scales and what's considered healthy and unhealthy. And I don't have time today to go into the health effects directly, but the way in which noise, particularly either on the daytime noise exposure or nighttime and sleep disruption exposure, can lead to real dysregulations in stress hormones, increases in blood pressure, increases in dysglycemia or affecting glycemic control, perpetuating obesity, and some strategies maybe on the individual, local, and more national level about using noise barriers, whether they're earplugs at night, to shifting to electric cars, lower noise tires, changing roadways. There are other strategies that we can do to reduce the effects of noise pollution. And analogously, light and ambient light overnight has been recognized recently as a particularly a potentially relevant and modifiable exposure. There's been some really elegant work to show that ambient light overnight increases your blood glucose, increases hormones related to fat deposition, potentially increasing obesity. It increases blood pressure, and that these are amenable to harm reduction strategies. So reducing ambient light and bedtime light exposure overnight, reduce or eliminate your use of screens at bedtime and certainly overnight, avoiding falling asleep in front of your TV or in front of your computer screen. Using sleep aids is relatively straightforward. Using a sleep mask can reduce ambient light exposure substantially and potentially lead to immediate health benefits. So some new and ongoing studies by our group. I am leading a trial that we're starting imminently to basically look at whether we can improve indoor air quality and lower blood pressure for residents in public housing with high blood pressure here in New York City, supported by the NIH. This would be a big deal for us to achieve using an air filter overnight in your bedroom over about 6 months. We should be starting this in June, sort of waiting for the further green light from the NIH. And a cardiology fellow working with me was recently given notice from the Doris Duke Charitable Foundation that they're going to support a trial to use portable air cleaners to lower blood glucose or blood sugar in individuals with prediabetes. And we're going to use continuous glucose monitors to measure the effects of using portable air cleaners and other relevant biomarkers of glycemic control in these individuals. So there's a lot going on. I think, there's both a local, national, international, and individual strategies to reduce some of the health effects. And there's a lot of things that I couldn't talk about. I focused on air pollution because that's, I think, the most common exposure source. And I think there are some cost-effective modifiable requirements. Let's see, some questions. We've gotten some good ones, so I will, I guess, kind of go to those now. Let's see. So thank you, everyone, for attending. I'm going to sort of, I guess, start answering some of the questions. Does that sound good, Anya? I'll read out the question and then maybe start to run through some answers.
Sure. Let's start with these perhaps, and then we'll go to the ones we've received live.
Yeah.
Thank you for that excellent talk. That was outstanding, really. Thank you.
Thanks.
Okay, so the first one here is, how can we protect our home environment from air pollution? You spoke to some of this, but maybe you could give us the highlights.
Yeah, so the biggest driver of indoor air quality in general is outdoor air quality. So if you live in an area that's let's say close to roadways, or in big urban centers close to roadways, considering using a portable air cleaner may be a beneficial strategy for a number of different health outcomes. Indoor air quality can also be modified separate from outdoor things, using appropriate ventilation when you cook, opening your windows, using a vent. That can meaningfully reduce kind of fine particulate exposure, which is different from fossil fuel combustion, let's say from traffic related air pollution, but can also, have downstream health effects over time. Let's see, I think that may have focused on the protecting the homes, and then other things, certainly focusing on home improvement strategies may be challenging to achieve population wide, but on an individual level of, improving, let's say, building seals with windows and high efficiency buildings can have meaningful air quality improvements that we think can translate into meaningful improvements in cardiovascular risk factors. But achieving that is a more complicated process, I think.
Well, so you talk about, the packs. Is there any online resources, sort of picking a portable air, filter, and where do we go from here? Like, how do we select one? And do you recommend any certain brands? And
sure. So, what I would say I don't recommend any certain brands. I think the EPA has a great website if you go to epa.gov or you search EPA air filters, they have a whole fact sheet about air filter types and ones that, what you want to look for. In general, if you look for air filters that are HEPA filters, stand for high efficiency particle air filter, they will remove over 99.5% of particles less than 2.5 micrometers and smaller. So they are larger and smaller. So they really take care of everything. You can buy those on Amazon for $100, or at your local hardware store often carries them, or Walmart, Sam's Club, etc. For less than $100. They're relatively cheap. You do need to change the filters on those devices depending on how often you're using them, about every 6 months, but they frequently come with an alarm that'll tell you when to change them. In general, if you're going to buy one or pick one area to focus on, doing it in your bedroom might be a beneficial strategy, just because it's maybe more of an enclosed environment. We know that blood pressure changes overnight matter potentially more than those during the day. And maybe improving indoor air quality at that time is highly beneficial. I think that was,
yeah. And now the HEPA filters, what about this MERV factor? How does that come into play? How do we pick a HEPA filter?
That's a good question. I'm not intimately familiar with the sort of MERV requirements. I think in general, that's why I was sort of scaling it to a bedroom. I think that does take into account the size of the filter, the size of the room, the power of the device itself. Ultimately, I am not an environmental engineer. I'm a cardiologist and focus on, risk factors in individuals and populations. So I rely on my environmental engineering colleagues to sort of give me some guidance there. But I think if you're focusing on one room, a personal air cleaner that cleans about 300 square feet are the sort of portable level devices. And usually those have a HEPA filter guided or appropriately designed device. You want to avoid, and I don't really think they're sold as much, air filters that are called electrostatic. Those are much less common or used, partially because they would generate ozone. And in general, it's harder to find those. You can still find them outside of the US. One comment from a colleague who I'm happy to see here, Dr. Ujueta at Mount Sinai, asked a question about using these air filters for primary prevention, which is really preventing heart disease in and of itself. Let's say the first time that you preventing a first heart attack or a first stroke versus secondary prevention. So that's a complicated question. There's a lot there. What I would say is that we need to first show that you can modify these risk factors. So blood pressure is one of the only surrogate outcomes that the FDA will accept for medications or strategies to reduce cardiovascular risk, because the relationship between blood pressure and heart disease is so tightly linked. We know and we think that using and improving air quality may be beneficial for reducing, let's say, heart failure hospitalizations for people that have congestive heart failure. We have some evidence that it may be beneficial for individuals after they've had a heart attack. But again, you'd have to have a study that would be prohibitively large, even for a secondary prevention population, to show a reduction in events with these strategies. As of now, I think if we can achieve a risk factor reduction, that would be a meaningful individual strategy, sort of potentially scalable on a population level to achieve.
Fabulous.
Yeah.
Okay, you touched a bit about noise pollution. That was so interesting, about the link between noise pollution and cardiovascular health. And so maybe you want to just give a quick brief overview there. But we also have a question here about light pollution and its effect on health. Is there a link to cardiovascular disease?
Yeah, so I sort of touched upon that briefly on the end, and I think there's a link to risk factors that are closely linked to heart disease. So there's evolving evidence about the links between, light pollution or ambient light overnight and during sleep hours, and its effect on dysregulation of your stress hormones, increases in blood glucose, increases in blood pressure. And because these risk factors are so closely linked to the development of heart disease, if you can address some of those, you can reduce that underlying risk substrate. There's really kind of a common soil element between a lot of these risk factors that function together. And the same thing may be true for noise. With a lot of these environmental exposures, whether it's air pollution, noise, light, they're modified by your individual status. So if you're someone who drinks a lot and smokes, your individual response to air pollution or noise disruption may be worse than someone who has better control of their cardiovascular risk factors. And that's a secondary push for kind of the main hat that I wear as a preventive focused cardiologist. Is there's the most important thing that you can do to reduce your health effects from, let's say, air pollution exposure is to focus on the big things that we know that drive heart disease risk, namely having a healthy diet, getting good sleep, controlling your weight, controlling your blood pressure, watching your cholesterol, not smoking. Those are sort of the big risk factor prevention. And these sort of non-traditional or individually modifiable environmental risk factors can play a role in addition to control of those traditional risk factors.
Thank you for that.
Sure.
We have these other questions here. Do you think people should avoid or minimize fragrances, parabens, phthalates in personal care products, laundry detergents?
Yeah, so it's an interesting question. I've done some work looking at the effects of what are called PFAs, or perfluoroalkyl substances that are common in plastics. I think a lot of the question of phthalates and PCBs or the other organophosphates, is their relationship as endocrine disrupting chemicals. And it does appear with plastics that and some of the fragrances that phthalates have environmental they're obesogenic, or they affect the development of diabetes. I think mitigation strategies there, I think using plastics less and using BPA free or bisphenol A free plastics is certainly a advantageous strategy. There is evidence about phthalates and plastic exposure with regards to tumorigenesis and cancer. And simple strategies like not microwaving your plastics if you're going to store something in it is one way to sort of immediately mitigate some of that risk, right? We know that there's a reaction where if you microwave store-bought plastics, those ubiquitous containers, that's a way of kind of directly leaching in or accelerating some of the leaching in of some of those organic phosphates in plastic. So if you're going to microwave something, do it in glass, right? Do it in something that's more inert. And I think shifting towards less of those obesogenic exposures may be a sort of background strategy as well.
Great. That was it for our pre-submitted questions. If you had any other thoughts or any other questions here to go through.
Yeah, so there's a good one about, I saw that you highlighted here, Anya, about using gas-powered stoves. It's something that I know has gotten a lot of press lately, that pick your favored or disfavored governmental agency is going to come take your gas stove. That's not what is going to happen. There are data, pardon me, that indoor air quality with gas stove usage is much worse compared to electric stove usage. I think with a lot of these strategies, it's a balance of feasibility and cost effectiveness. It may make sense for new developments as we shift to a more renewable based energy production model to use electric over gas stoves. But it is not a feasible change to make in a lot of existing buildings for a number of reasons. So, but that is an active area of investigation that I still think we're learning a lot about. And ultimately, as a cardiologist and a clinical trialist, we need to show evidence that making certain changes improves outcomes and helps people live longer and live freer of disease. And that is a harder strategy to do with a lot of these complex exposure elements. But I think in the case of something like indoor air quality and personal air cleaners, if we can show that you can lower blood pressure, it moves something like air pollution into the realm of a individually or personally modifiable risk factor, maybe like salt exposure and the effects of dietary salt reduction, which I think would be a compelling and maybe new dimension to an individual and public health strategy.
Fantastic. Well, I think that'll conclude our webinar today. Dr. Newman, thank you for giving such an excellent talk and for answering all of our questions. And thank you to our audience for joining us today. In follow-up, if you'd like to contact us, we have highlighted our email here. Of course, we've shared how to keep in touch. We have our website, NYULangone.org/heart health lectures. We hope that you'll join us for our May lecture looking at the gut microbiome. And again, thank you, Dr. Newman, and thank you for everyone who joined us today. And happy Earth Month.
Thanks, Anya.
Thank you. Goodbye.
Bye.
Bye, everyone.